Good afternoon, everyone. Welcome to the American Academy of Actuaries webinar on the drivers of 2019 health insurance premium changes. I am Cori Uccello, the Academy's Senior Health Fellow, and I'll be moderating today's webinar. Each year, the Academy puts out an issue brief that provides an overview of the next year's premium changes. We focus on the premium changes for the individual market coverage that is subject to Affordable Care Act rules. And I will cut to the chase. For 2019, the major drivers of 2019 premium changes include the underlying growth in healthcare costs, also known as medical trend. Recent and pending public policy changes, including the elimination of the individual mandate penalty and the expanded availability of association health plans and short-term duration insurance plans. Changes in the individual market risk pool composition and insurer assumptions, and actions taken by particular states, such as new reinsurance programs or individual mandates, or rules that would facilitate or prohibit the sales of plans that don't meet ACA requirements. Our speakers today will provide additional detail on each of these factors. In addition, they will provide detail on the impact of cost-sharing reductions, or CSRs, on premiums and premium changes. I know this is a complicated topic, so we thought it would be helpful to get a little more into the weeds on this. Today, I'm joined by two actuaries who were involved in drafting our issue brief, Barb Cleaver and David Shea. Barb is the chair of the Academy's Individual and Small Group Markets Committee. David is a member of the committee. Barb will discuss the major premium drivers, and David will dive into the CSR issues. The webinar is scheduled to last an hour. The formal presentation should last about 40 minutes or so, leaving us plenty of time for Q&A. We'll hold all questions until the end, but please feel free to submit questions throughout the presentation using the Q&A feature in the bottom right corner of your screen. We'll try to answer as many questions as possible within the time allotted. So with that, I'll start by providing some context. Premiums reflect several factors. The main component is projected medical spending, which in turn reflects who is covered and the composition of the risk pool. Other premium components include administrative costs, taxes, and profit. Laws and regulations can affect each of these components, as well as how premiums vary among individuals. It's also important to understand the long lead time that's needed when insurers develop their premium rates. They have to build in time to develop plan designs, perform actuarial value testing, finalize provider contracting, review and adjust assumptions, and project claims. In order to file preliminary rates by June, insurers typically start this activity before the end of the prior year. So with that, I'll turn things over to Barb, who will cover the major premium drivers for 2019.
Thanks, Cori. I will be going over the drivers of the 2019 premium changes. Cori basically listed out the major drivers that we identified earlier, but they do include the underlying growth in healthcare costs, recent and pending policy changes, changes in risk pool composition and insurer assumptions, and state actions. So I will go over each of these drivers in detail. The first major driver is the underlying growth in healthcare costs. It's referred to as medical trend in rate filings. Medical trend includes the increase in per unit costs of services or price inflation, changes in utilization of services, and changes in the mix or intensity of services. Medical trend for 2019 is projected to be around 5 to 8%. This is consistent with 2018 projected trend. We expect prescription drugs to continue to be a driver of medical trend, but we note that its growth has leveled off and is expected to be only slightly higher than medical trend. There are several major policy changes impacting premium rates for 2019. The first involves cost-sharing reduction subsidies, also called CSRs. Insurers that offer plans on exchange must provide CSRs to lower income enrollees that purchase silver plans by providing silver plan variants with higher actuarial values. The CSRs used to be directly funded by the federal government, but are no longer being reimbursed. In most states, insurers increased 2018 premiums to cover the loss of CSR reimbursement. However, states varied in how the premium was loaded. Some states directed insurers to load only the silver on-exchange premiums in order to shield the off-exchange enrollees from the load. Other states directed their insurers to load all silver plans on and off-exchange, and a few states directed their insurers to load across all metal-level plans. For 2019, states may change the manner in which it is loaded. For example, a state that requires loading over all metal level plans may change to directing their insurers to load only silver plans. Additionally, insurers could exchange their assumptions around the CSR load, which would impact the premium changes. David's going to go into more detail on the CSRs later in the presentation. The next major driver is the elimination of the individual mandate penalty. Under the tax reform bill, the individual mandate penalty was changed to zero for 2019 and beyond. The mandate was intended to encourage healthy people to enroll in the ACA pool, leading to a more balanced risk pool. When developing 2018 rates, some insurers anticipated a weakening of the mandate and increased the premiums accordingly. The premium impact of fully eliminating the penalty in 2019 will reflect what hasn't already been incorporated into premiums. Insurers that did not build in the loss of the mandate previously will need to build in the full amount for 2019. We note that subsidy-eligible people may be less sensitive to the mandate since premium subsidies encourage their enrollment. So states with higher shares of premium subsidized enrollees may see less of a premium increase. We also note that the availability of alternative coverage, such as short-term limited duration plans and association health plans, could exacerbate the impact of the mandate removal because it gives healthy people other options of coverage. The final policy change we identified is the expansion of association health plans and short-term limited duration plans. The proposed STLD rule lengthens the maximum duration of these plans from 3 months to 12 months. The final association health plan rule was released last week, and it allows more AHPs to use the large group rating rules, and it also expands eligibility to sole proprietors. So in this way, it could impact both the small group and the individual market. STLDs and AHPs will be able to use different rating factors than is allowed in the individual and small group market. This could include age greater than a 3-to-1 ratio, gender, occupation, industry. In addition, short-term limited duration may use underwriting and use pre-existing condition exclusions. In addition, these plans will not be subject to the EHB requirements, which could lead to leaner benefits being offered. This could make these plans more attractive to healthier enrollees, leading to the deterioration of the ACA risk pools and higher premiums. The AHP rule has staggered effective dates beginning September 1st, 2018. The short-term limited duration rule has not been finalized yet, leading to uncertainty on the contents of the final rule and when it will become effective. Insurers must make assumptions on which alternative coverage sources will be available in their market for 2019 and their impact on the risk pool. I'd like to note, too, that states may have stricter laws or regulations governing AHPs and STLDs, which would impact the needed premium changes for the ACA coverage in their state. Another major driver is changes in risk pool and insurer assumptions. Some of the policy changes previously discussed are expected to lead to a deterioration of the ACA risk pool. But insurers also consider enrollment and take-up rates. As enrollment drops, average health costs per person are expected to increase, assuming that healthier whether individuals are foregoing coverage or finding alternate sources of coverage. Marketplace enrollment declined slightly in 2018 for the second year in a row. If insurers expect this to continue, it will put upward pressure on rates. Off-exchange enrollment matters too due to the single risk pool provisions, but public information is not available on the size of the off-exchange market. Enrollees on exchange are shielded from premium increases by the subsidies, but premium increases directly impact off-exchange enrollees. So it is possible that off-exchange enrollment drops to a greater extent than the marketplace. It's important to note that the enrollment changes will vary by state due to local market conditions. In addition to risk pool changes, insurers will update assumptions based on their most recent experience, and the premium change for 2019 will reflect how the experience differed from the assumptions built into 2018 premiums. Another major driver for 2019 is state actions. Premium changes always vary by state due to local market dynamics. For 2019, some states have implemented or are considering other policies or programs that can impact premium changes. Some states are imposing an individual mandate, which would counteract the federal elimination of the penalty. Several states have implemented a reinsurance program, and other states are trying to set up reinsurance programs. Reinsurance funded by external sources reduces premiums in the first year of coverage by partially offsetting the cost of high-cost enrollees. And some states have rules which would either facilitate or more strictly regulate plans that do not comply with ACA requirements. In states that facilitate the alternative plans, the ACA risk pool could deteriorate, increasing premiums. And states that prohibit the sale or more tightly regulate these plans may mitigate some or all of the premium increase. We also described the other drivers that we do not consider as major drivers. The health insurance provider fee is suspended for 2019, so this will result in about a 1 to 3% premium decrease. There can be changes in provider networks. States are now evaluating network adequacy. If more restrictive networks are allowed, it could lower costs, whereas if wider networks are required, it could increase costs. Insurers include benefit plan changes frequently. They may be based on updates to the actuarial value calculator, which reflects yearly changes in costs. They may reflect the increased maximum out-of-pocket limit that's updated every year, or based on market competition considerations, that any benefit plan change will impact the premium. Market competition can also impact premium levels. More price competition in markets with multiple insurers has been shown. Insurers were pulling out of some markets in 2017 and 2018. If insurers decide to re-enter in 2019, this could lead to more price competition. Provider compensation and reimbursement is also important to premium levels. Provider consolidation may improve quality and efficiency of healthcare, but it also increases the provider's negotiating power, leading to some upward pressure on rates. However, some insurers are pursuing provider reimbursement strategies, such as ACOs, to shift some risk to providers. In these arrangements, providers are incented to deliver cost-effective and high-quality care, which could put downward pressure on premiums. Changes in administrative expenses will impact the premium levels. Decreased enrollment for an insurer can lead to spreading fixed costs over fewer people, which could increase premiums slightly. However, the MLR limits the amount of premium that can be used for expenses. And finally, geographic factors are used in pricing. Insurers can vary rates by rating area within a state to reflect provider cost differences. Any changes in these factors will impact the overall premium change. Insurers also may modify their service areas within a state or the rating regions that they participate in, which could impact their premium increases. And now I'm going to turn it to David to discuss CSRs more fully.
Thanks, Barb. As mentioned before, I'm going to take a few minutes and try to unpack these cost-sharing reductions and their impacts on premiums and premium changes. Just a little bit of history behind them. As mentioned earlier, individual exchange carriers must offer at least one gold and one silver plan. And every silver plan must have what's called 3 variations. The 70% is the standard silver plan actuarial value, and for every standard silver plan that's offered, the carrier must offer 3 variations with ever-increasing actuarial values that you can see there on the screen in the chart. Before the federal government stopped reimbursing, it was paying carriers the increased amount of cost sharing, since carriers cannot charge different rates for those silver plan variants. They must all have the same rate as the standard silver plan. When the government stopped reimbursing carriers for the increased cost sharing amount, the carriers had to decide how to approach this loss of revenue or loss of claims costs, and each state had their own approach as to how that was going to be treated. Some states made requirements on carriers, other states had suggested approaches, and some states were silent. And so the premium loads were done different ways in different states. And the premium loads are reflected the premium loads are how they were reflected and loaded, which share of enrollees are expected to receive the subsidies, and the carrier also must consider the distribution of enrollees by each silver plan variant, because they can only adjust rates with one factor based on the distribution of those silver plan variants for each carrier. Now, in 2018, when the funding stopped, the premiums were increased for cost-sharing reductions, and it varied by state. Some states required that they load all plans for the loss of CSRs. This generally resulted in about a 3% increase on average if the carrier applied the load to all of their plans. Some states directed carriers to load both on and off exchange silver plans, and other states required or suggested that carriers load only their exchange plans, which are the plans with the silver, with the variants, the silver variants. Generally speaking, the silver plan exchange only load resulted in about a 20 to 23 to 24% increase to silver plans. Some carriers, if they had fewer CSR eligible enrollees, that load would be lower. So it was incumbent upon the carrier to get it pretty close by distribution of silver plan variants, because they could only use one load to load their silver plan. Now, since subsidized enrollees pay the full freight of the cost, any load that's applied to any plan is fully felt by those enrollees that don't get a subsidy. And obviously their choices will be based on how the carrier in their state chose to load for the lack of CSRs. Now, for enrollees that get premium subsidies, they are totally shielded from the increase due to the CSR load. I'll give you a quick example. So let's say that a person earning $20,000 a year is required to pay 4% of their premium based on the law, and this results 4% of their income it should go toward their health insurance premiums. And for a $20,000 person at 4%, that means they should be able to pay $800 a year for their health insurance. Well, some folks are faced with annual health premiums much, much higher than that. So let's say that for this person who should pay $800, their health insurance premium for the year is $4,000 without the load, and they chose a silver plan. So they get a subsidy of $4,000 minus $800, or $3,200. If the carrier chose to load that plan by 10%, the new premium is $4,400. However, the amount the person is required to pay is still $800. So their subsidy goes up to $3,600. That also means they can use that subsidy to buy a lower cost bronze plan and pay much less, or possibly get a bronze plan for free, or they could buy up and pay a little bit more of their subsidy and get a low cost gold plan. In 2018, it was noted that the exchange enrollment shifted. Generally speaking, up until 2018, at least 70% of nationwide enrollment was enrolled in silver plans, primarily because that's where you get the subsidy. And what was noted in 2018, movement shifted toward bronze plans, and to a lesser degree, shifted toward gold plans, which gets back at the reality I mentioned earlier. When the CSR loads were implemented, it just meant greater subsidies for subsidized enrollees. And so what this movement indicates is folks use those subsidies primarily to purchase lower cost or get a free bronze plan, or if they were interested in a higher cost plan with lower cost sharing, they would look at a gold plan. Use a bit more of their subsidy, but again, it could be a value to that individual. Now, what would happen for carriers is it might indicate that those who qualify for cost-sharing reduction subsidies are more likely to purchase the richer plan. And if carriers didn't assume this type of shift into their richer plans, the 87% and the 94% AD, this could mean that their CSR loads going into 2019 may need to increase. Now, moving forward into 2019, word has gone out that the federal government will continue to allow silver loading for 2019. They were fairly silent on the issue for 2018, and there had been some concern that they were going to come out and direct carriers how to load for CSR, but they didn't do it for 2019. And it's possible that they will reconsider this for plans going forward into 2020. Now, you have to be very cognizant of what each state allowed to happen in 2018 and moving into 2019. If carriers were prohibited from loading just the silver plans and were instead required to spread their increases across all their metal levels, the loads for premium silver plans would go down, but the loads for the other metals would increase, obviously. Again, everyone needs to pay very close attention into what happened in 2018 for each state and what will happen in 2019. Now, the impact on subsidized enrollees will, if their premiums go up, they can use those subsidies toward metal tiers, and those subsidies the metal tiers toward other metal tiers would go down, reducing any premium advantage of the bronze plan compared to the silver plans. This could also increase premiums for non-subsidized enrollees. They would no longer be able to obtain coverage without the CSR load. As mentioned earlier, some states have changed how they are directing carriers to load premiums. Some states that didn't allow it in 2018 are allowing it in 2019, and vice versa. With respect to this, it is incumbent upon every pricing and filing actuary to be very familiar with the directives in your state as to how CSR loads will be treated. And with that, I will turn it back over to Corey.
Sorry about that. I was on mute. So thank you, David. Now we'll move on to the Q&A. I want to remind everyone to submit your questions via the Q&A feature on your screen. I'd also like to encourage you all to respond to 2 polling questions that you'll see at the end of the webinar. We really welcome your feedback on this briefing and any ideas you have for future webinars. And if you have any questions about this briefing or other Academy activities, please contact David Lind, whose contact information is on the last slide. Okay, so we do have some questions, and the first one relates to the effects on premiums of the individual mandate, the AHP's expansions, and the pending short-term duration plan expansions. We gave the direction of what they can do to premiums and premium changes, but not the magnitude of those effects. Can either of you provide any information regarding the magnitude on premiums and premium increases of those different policy changes?
Yeah, this is David. I seem to recall from my experience as a state regulator and some publications with respect to the individual mandate, increases anywhere from generally 5% to 10%. I don't recall seeing anything higher than 10. It's a little bit too soon. I am sure carriers have included impact of AHPs and short-term plans in their 2019 rate filing. Those are going to be a little bit more, now this is a technical term, but they're going to be a little bit more squishy because, number one, there are no final regulations yet out on short-term plans, so kind of don't know the rules of the road for them. And for AHPs, it's going to be a matter of carriers trying to figure out which of their pools, individual, small group, or both, will be affected by the presence of AHPs and to what degree. And since the AHP rules just came out, there really wasn't a huge amount in the rules that pointed carriers toward some kind of order of magnitude of what's going to happen with AHPs in their market. So it's going to be up to each carrier to figure those things out right now.
Yeah, and this is Barb. And the presence of AHPs and SPLDs could be expected to vary greatly by state. So it's definitely going to differ by state. And it also depends on whether states have regulations around the formation of AHPs and the regulation of them.
And while we're on the topic of AHPs and short-term plans, we have kind of a process question in terms of the AHP rules the final rules were released after many carriers already submitted their initial rates for 2019. And since the short-term rules aren't out yet, carriers submitted rates before those rules have been finalized. So, what does that mean for the rate filing process? Did carriers already include what they thought was going to happen so they won't have to change their rates? Or will they need to submit another set of rates that reflects those policy changes? And if premium changes were needed, are state regulators going to allow a different set of rates to be submitted? So kind of talk us through this kind of process of the rate filing. given these new policy changes?
Okay, Corey, sure. This is David again. I'll take that one. It really is a function of whether or not a state will allow a carrier to refile their rates once they're originally submitted. There are some states where the filing dates are much later. In fact, I think there may be a few states that their filing dates haven't even come up yet, whereas in other states, their filing dates have passed. It really boils down to whether the state will allow a carrier to resubmit. I can say from personal experience in Virginia, carriers are allowed to resubmit their filings as they are in other states. And in most of the cases in the last few years, carriers have chosen to resubmit their filings after their risk adjustment data comes out. And so, again, the process is whether or not you're allowed to refile and how soon or how late the deadline is in your state to file.
And staying on the AHP topic, it's a staged implementation, but the first stage of this is in September 2018, where HPs are going to be able to be available for certain associations. So what effect does that have on 2018 rates? Presumably none, because rates have already been finalized and are in place, but what does that mean for just the marketplaces for 2018?
This is Barb. I'll take that one. So you're correct. They can't change their 2018 rates, especially in the individual market, and it's too late for small group quarterly filings too, I think. So what if there is an impact due to AHPs in either market during 2018? It's basically going to be reflected in the experience of those insurers. So their rates may be slightly inadequate based on that. But of course, there's other factors that impact rates.
So we talked about policy changes such as getting rid of the individual mandate penalty, AHPs, and short-term plan expansions. But one topic we didn't talk about was this litigation between Texas and the U.S., where Texas and some other states are suing to say that because the constitutionality of the entire ACA is in question. And then recently, the Department of Justice declined to defend the constitutionality of the mandate and argued that the guaranteed issue and community rating provisions would also need to be struck down, but not other elements of the ACA. So given that litigation, is that case at all affecting 2019 rate filings?
Oh, this is Barb again. We've had a long period of uncertainty around the ACA market, and obviously this lawsuit doesn't help that. However, it is expected for this court case to take a long time to make its way through the courts. So I'm not sure that it's going to be having a direct impact on the 2019 rates, other than just adding uncertainty around the whole ACA market.
And speaking of uncertainty, last year there was a lot of activity during the spring and summer regarding repeal and replace legislation. Just recently, there was another proposal put out, another repeal and replace type of proposal that was introduced. What effect, if any, is that kind of continued activity affecting 2019 rates?
So I guess I would just say that it's, again, just a continuation of uncertainty around the ACA markets and whether they'll be continuing in their current form.
Okay, now we have a question on insurer participation. So when the individual mandate penalty was repealed, there were concerns that insurers would leave the market, in part because the concern that healthy individuals would decide to forego coverage, whereas the healthy people would stay in, and that adverse selection would cause uncertainty and disruption and might cause insurers to rethink their participation. However, this year we're seeing reports that insurers seem to be expanding ACA participation, at least in some markets. Can either of you explain a little bit about what's going on here and, what the reaction to the mandate penalty may mean for insurer participation, given the new expanded AHPs and short-term plans?
I can take this, and Barb can fill in the blanks for me. I think one of the key elements, Corey, in all of this going into 2019 is the relative certainty that carriers have as to how 2019 is going to play out compared to years past. When carriers got wind a couple of years ago that the government was going to stop funding CSRs, they really didn't know, and that was a big dollar item for them, and so they were concerned about that. And then the talk of getting rid of the individual mandate has been going on for several years. CMS has gradually whittled away at it by first acknowledging that there's going to be a rather lax enforcement, and then when the individual mandate penalty eventually went away, that took all of the uncertainty away about it. So carriers now feel comfortable about CSRs, comfortable about what's going to happen with the individual mandate because it's gone. AHPs and short-term plans, probably not immediate impact for 2019, but further down the road, particularly when the rules for the short-term plans come out, it's going to be more of an impact later on. So when you roll all this stuff together, bottom line is, at least the way 2019 is sitting compared to a few other years, carriers are feeling a little bit more on solid ground. And I also believe that their ACA experience has started to improve somewhat. And so for those reasons, I think we're seeing a little bit of an increase in carrier participation. And Barb, if there's anything I left out, please feel free to.
I think you covered it.
Okay, I want to remind people to use the Q&A feature on the bottom of their screen if they have any questions for our panelists. Thinking bigger picture in terms of premiums for 2019 and even in the longer term, are there things that the states or the federal government can do now to lower premiums for 2019? Is it too late for that? And in the longer term, what can be done to lower premiums? Things that we've heard about in the short term include, as Barbara said previously, on the state level, states thinking about reinsurance, implementing their own mandate, implementing limits on HPs or short-term plans. We've also known that there have been proposals out there that would implement auto-enrollment. Do you have any comments on these kinds of provisions, whether it's too late to do anything now for 2019, and if so, what should both federal and state policymakers be thinking about in the longer term to help keep premiums down?
I can take this one. So it is really late in the filing process to do anything right now for 2019 if the process hasn't already been started. For reinsurance, a state would probably need legislative activity, and most of them are doing 1332 waivers along with their reinsurance programs, and those types of applications take some time to work their way through CMS and the state process. And for insurers to be able to price in the reinsurance program, they need to have final parameters. And, as we've talked, many insurers have already filed their rates, and rates need to be final, completely final in September. So it's really kind of late to start that process at this point. And pretty much the individual mandate, that would also need state legislation. And state legislatures would need to determine how to collect any penalty that they would have for the mandate. And that's also difficult for states who have no state income tax to implement. States could look at rules, to more tightly regulate AHPs and STLD plans in their states. I'm not sure if they could get that done to impact 2019, though. And as far as going forward, though, all of those items could be used by states to lower premiums in 2020 and beyond. I think you also mentioned auto enrollment. At least one state has looked at implementing an auto enrollment plan. Auto enrollment could help a risk profile of an individual market if the logistical issues involved with auto enrollment were worked out. There are significant logistical issues, including identifying the people who would be eligible for the insurance because they're not eligible for any other type of insurance, and also selecting an appropriate insurance plan that would have the premium fully covered by subsidies. So it's not an easy lift.
I will highlight that the American Academy of Actuaries is currently working on a paper on auto enrollment, and is going to be discussing some of those issues that Barb just raised. So just want to put that out there to keep your eyes out for that. It should be up this summer. So one of the reasons that premiums are high and increasing is because of underlying medical costs. Medical spending is high and is growing. So one way to get at lowering premiums is to find a way to contain medical costs. And we got a question from somebody asking about the role of insurance regulators in providing oversight of charges by providers. And I think just more generally, do state regulators, what kind of authority or leeway do they have with respect to medical spending and the prices charged by providers?
Okay, I can take that. As with everything, it depends upon the state. Maryland, for example, sets their hospital rates each year, so they've got the legal authority to do that. In many other states, they don't have any type of regulatory oversight or authority over charges that medical providers have. So in many cases, it will take laws and regulations for them to get such oversight. In some states, at least the relationship between a state agency and a medical provider is sometimes not housed with the Department of Insurance. And so from an insurance oversight, it requires a lot of cooperation between state agencies, and even so, without any type of legal authority, states do have authority to require that carriers provide access to their reasonable access to their networks, and to have certain providers in their networks and things like that. But in the vast majority of states, they don't really get anywhere near the underlying cost of, at least the charges that providers have. That's been the sole dominion of the carriers and the type of negotiated arrangements they can make. As we are all very well aware, carriers struggle with trying to reduce the cost, the charges of their medical providers, so it's a big challenge there. I guess bottom line is, in a lot of areas, there's just not the legal authority to do so yet.
All right. Well, yes, go ahead.
I do see. Hey, Corey.
Yeah.
I do see one question down here about. Please go over why CSR loads are going into 2019. They need to increase again, and I think it'll be helpful to go back to this chart that shows the actuarial values of the silver plan variant. There's two ways, at least two ways, that CSR loads could be going up again in 2019. One simple way is if a state required the carriers to spread the cost over all their plans last year, and then this year requires carriers to only load the silver plans, and let's say the average load last year was 3% across every plan, and the state has come in this year and said, for 2019, you must load only the silver plan. So the 3% loads on the platinum, gold, and bronze plans go away. So those rates go down, all else being equal. And the silver plan load that was 3% now turns into 20%. So the other metal levels have a slight rate decrease. The silver plan has a pretty substantial increase. That's one way the loads could go up in 2019. The other way is a simple matter of distribution. Carriers have to price using one factor to cover all three of those silver plan variants. So, for example, if a carrier happened to have everyone enrolled at the 73% silver plan variant, then they would load, this is an example, but they would load their standard plan 3% to cover that additional cost. Well, if it turns around the following year and everybody has enrolled in the 94% AD, they miss the mark by about 20%. So it's a function of how it was loaded last year and how it is loaded this year, and also whether the carrier guessed reasonably well on the distribution of silver plan variants. And I hope that was helpful in clearing that up.
All right, thanks, David. That seems to be all the questions that we have for today. I want to thank everyone for listening in and remind you that a couple of polling questions will be available for a few minutes at the end, and we look forward to your feedback on this. So thanks again, everyone, for participating, and have a great day.